So what about choice of CDK, just as our practice patterns have evolved a bit? I think we all probably utilize all of the CDK4/6 inhibitors in our practice, but just any comments people want to make. We did take a look at the Monarch 2 and 3 subset analyses in some detail, looking for the higher risk patients versus the lower risk patients. Now, of course, all of the trials, both in the first and the second line, if you look at all of the population, the results are just absolutely superimposable, But it's interesting, as we know, the patients with the really virulent, aggressive disease is a smaller percentage in the metastatic setting. And so those patients won't necessarily be reflected in the overall trial population. So, that's the first thing to say, is there are no comparison data, head-to-head comparison. And all of the studies have done subset analysis, and every single subset benefits, across, all disease characteristics. So we know this. But in the Monarch 2 and Monarch 3, looking at patients with liver metastasis, grade 3 disease, progesterone receptor negative, and also short treatment-free intervals. So, recurring, within a short period of time of adjuvant endocrine therapy or on adjuvant endocrine therapy, seeing, robust response differences of 30% or more, as well as improvements in PFS, Also benefit in patients with more indolent disease, bone only, progesterone receptor positive, lower grade, also benefit, but, interestingly, to a lesser extent. So, I have sort of developed in my mind that if I have a true luminal B, a real virulent, full throttle luminal B, that I will utilize abemaciclib, and, of course, I was involved in the subset analysis, so I'm very familiar with the data, but also I think the continuous inhibition of CDK4/6 and maybe a little bit of broader spectrum, against CDKs. I think, again, we don't have head-to-head comparisons, so we just have to make these clinical decisions based on our gestalt, if you will. I must say, too, it is also a bit influenced by the later line patients that we treated in the beginning when we first had these agents, and we had patients getting, I had patients getting responses having had everything, and they were on abemaciclib and with significant liver disease. So I had some anecdotal experience too that did kind of sway me in that regard. And when it comes to more indolent luminal A disease, I want to go for the least toxicity that I can get. And there I'm utilizing the palbociclib and ribociclib pretty much exclusively. So that's what I have just come down to in my practice. But how do you think about it, Ruth?
I think you make some very valid points. I do have tended to use palbociclib in the main. But I think your points certainly would certainly make me think a little bit in a patient that you described. I think if patients have brain metastasis, I do tend to go to abemaciclib because the data is stronger there. But other than that, I think they're all very effective. I think we don't have the same data you're talking about, I think, with the other ones, so I don't know. But
yeah, not exactly
I do like your algorithm. I think that makes sense. But certainly, for CNS, I would certainly think about abemaciclib. I think for leptomeningeal disease, unfortunately, we don't know. I certainly would recommend it for a patient, abemaciclib for a patient with leptomeningeal disease, but I don't know how well it would work, honestly.
Mm-hmm. Yeah. How about you, Kevin?
Yeah, I agree with Ruth's comments, and I also think what you were mentioning in terms of that treatment-free interval, right? So if you think about the Monarch 3 subsets, which had that treatment-free interval, like that 3-year cutoff, those that were less than 3 years, mm-hmm. Which are really bad actors, right? Patients who are on hormonal therapy and then recurred within that time period. The difference in the Kaplan-Meier curves was quite notable, right? With a hazard ratio that was less than 0.5. So, I think your point is well made, and I can see really where you're coming from based upon those data.
I think we have to make decisions, and I think that this is a nice way to parse it out. But I don't know that the subset analysis really tells us that there's a difference between the agents. We did a subset analysis in the Paloma 2 trial and looked at all these different disease-free intervals, and there was no difference. The hazard ratios all line up. And one of the things about the Monarch data is that abemaciclib works really well probably across all of the subsets because the medians weren't reached in some of those really good prognosis subsets. So I wonder what we're going to see in the longer follow-up, where there's going to be still a really big difference favoring abemaciclib, even in the good prognosis group. So I kind of feel like, when we look at these forest plots, that basically the agents work across multiple different subgroups, prognostic subgroups, and I think that just like when we use the AIs, we have to decide how we're going to give the drug. So somebody who can't really keep track of their pills, I have somebody on capecitabine now, giving continuous dosing with abemaciclib is good. Somebody who has a lot of neutropenia or bone marrow dominant disease, where they have low counts, abemaciclib is a really good choice. And maybe what you're parsing out would be more visceral disease for abemaciclib, or palbo for somebody who has bone only. You have to make some decisions there. But I'm not totally convinced that there's differential benefit.
Yeah, because the subsets haven't been done exactly the same across all the different studies. That's the thing. So we can only look at the data we have.
Right.
Yes.
I also think that Hope's comment, that subset that we're talking about is a small number, right? It's less than 100 patients. So to really read significantly into it, which should be done with some caution.
Yes. It's interesting just to see a little snapshot of where we are in practice.